Hola, buenos días. Bueno, vamos a comenzar la sesión de comunicaciones orales sobre páncreas y vías biliares. Pero antes de comenzar con las comunicaciones, tenemos la suerte de contar con nosotros con el profesor DiMagno, que viene directamente desde Michigan, para contarnos en una charla que a priori parece muy atractiva sobre el diagnóstico y el manejo del páncreas divisum. Dr. DiMagno.
I'd like to thank the organization of the SEPD, as well as the program organizers and my moderators for the invitation to present before you today. My task here is fivefold. I'm going to address the historical background of pancreas divisum, address the question, does pancreas divisum cause pancreatitis, address 4 criteria for causality, review the placebo response for pancreatic pain, as well as alternate explanations for idiopathic pancreatitis. Pancreatic duct structures were identified long before there was recognition that the pancreas had a physiologic secretory function. At the University of Padua in 1543, Andreas Vesalius described the pancreas as pulvinaris, or protective cushion for the stomach. At the University of Padua, additional understanding grew in recognition of the main pancreatic duct. This was discovered by George Worsung in 1642 in a human cadaver. With this copper engraving, Worsung disseminated these observations to major scientific centers in Europe. This remains on display at the University of Padua. Additional structures of the pancreas were discovered in the 17th century, including the major papilla, as well as the accessory duct. The major papilla, or ampullative fodder, was discovered by Samuel Collins 35 years before Abraham Fodder and Giovanni Santorini. The accessory duct, the duct of Santorini, was discovered by Johann Rode in 1661. This was 60 years before Santorini. The 17th century led to discovery of additional normal anatomic variations. Among these include pancreas divisum, defined as failed dorsal and ventral duct fusion during embryogenesis. This was identified by Regnier de Graaf in 1664, and later Meckel explained the origin, and Joseph Hurdle depicted pancreas divisum and coined the term. During the second month of fetal development, the pancreas results from intestinal rotation and fusion of the dorsal and ventral ducts. Failed fusion results in pancreas divisum, which is showed in the lower left-hand panel. In this scenario, the dorsal duct drains the majority of the pancreas, and the short ventral duct drains the inferior portion of the head of the pancreas. During the 1970s, pancreas divisum was increasingly discovered by ERCP and led to the question of whether pancreas divisum caused pancreatitis. The left panel shows a truncated but normal-appearing ventral duct in a patient with pancreas divisum. The right shows a normal dorsal duct. We'll return to this patient. It is controversial whether pancreas divisum causes pancreatitis. A problem in the literature is that authors use a variety of different terms for pancreatitis. I list 4 here. Another problem is that clinical data is frequently limited to exclude other causes or other explanations for pancreatitis, and I list a number here as well. We previously assigned the term idiopathic pancreatitis to encompass diagnoses of acute and chronic pancreatitis made by others. The main point from this slide is the title, and that is Idiopathic Pancreatitis Conforms with Natural History of Idiopathic Chronic Pancreatitis. Now, idiopathic chronic pancreatitis has 2 phenotypes, an early onset and a late onset phenotype. It is important to recognize the natural history of idiopathic chronic pancreatitis, which is that recurrent episodes of painful attacks during the early course of the disease when hallmarks of chronic pancreatitis are not present. Secondly, episodes occur at variable intervals at months to years. It is also meaningful to categorize chronic pancreatitis in one of two categories. First, relapsing chronic pancreatitis. It's an older term by Comfort, which is relapsing pain not recognized clinically as chronic pancreatitis, but having pathologic changes of chronic pancreatitis with or without known causes. Secondly, established chronic pancreatitis, which fulfills Mayo Clinic scoring system or other standard clinical diagnostic criteria. Now, it's also important to quickly review the spectrum of idiopathic pancreatitis. With a first attack of acute pancreatitis, 10 to 20% have no cause identified despite CT or ultrasound or labs. Of these, endoscopic ultrasound identifies a cause in about 80%. With a second attack of pancreatitis, this occurs less than 15% of patients. Most have an identifiable cause of recurrent acute pancreatitis. Few have no identifiable cause, a term called relapsing chronic pancreatitis, which we just reviewed. A common identifiable cause of recurrent acute pancreatitis is a biliary source. Data that favors relapsing chronic pancreatitis are genetic abnormalities. Now, this is an important point, and we're going to come back to this again. It is uncommon that investigators prospectively follow and test patients with idiopathic pancreatitis. 3 studies have done so, and the pooled data from these studies indicates that over 50% of patients will have an identifiable cause, primarily idiopathic chronic pancreatitis or a biliary source. Now, understanding the natural history of idiopathic chronic pancreatitis is relevant to patients with idiopathic pancreatitis and pancreas divisum, because up to 53% of patients with idiopathic pancreatitis and pancreas divisum have evidence of chronic pancreatitis. Now, this is a quick case of a patient with idiopathic pancreatitis and ERCP evidence of pancreas divisum. She presented at age 26. She had 5 episodes of pancreatitis beginning at age 11, had a cholecystectomy at age 24, no gallstones were found. An ERCP performed at age 26 showed pancreas divisum, but otherwise normal appearing ducts. She had a surgical sphincterotomy and remained asymptomatic until age 28 when she developed recurrent attacks of pain and a 4-fold increase in serum lipase. At age 30, she underwent a repeat ERCP. The left panel shows an abnormal dilated ventral duct, and the right panel shows abnormal dilated dorsal duct consistent with chronic pancreatitis. Importantly, there was no stricturing or stenosis at the orifice of the dorsal duct. It was wide open. Now, we previously suggested 4 criteria that would need to be fulfilled if pancreas divisum causes pancreatitis, and I stepped through each one of these. The first criterion is that the prevalence of pancreas divisum should be greater in idiopathic pancreatitis compared to the general population. Now, we examined the prevalence of pancreas divisum in pancreatitis versus no pancreatitis group by looking at 4 types of studies. On the left, autopsy, ERCP, MRCP, SMRCP studies. The second column shows the number of studies reviewed. The third column shows the number of studies for which data was available. And the fourth column shows the number of patients who were included in the analyses. This bar graph shows the prevalence of pancreas divisum in 95% confidence intervals for each of the 4 study types shown on the right. For each of these groups, we show the no pancreatitis and pancreatitis groups. In the autopsy studies on the top, the mean prevalence is 8% for pancreas divisum. For the ERCP group, the prevalence of pancreas divisum appears to be higher in the pancreatitis versus no pancreatitis group, but this prevalence is almost the same as the prevalence in no pancreatitis for the autopsy. In the MRCP, MSRP studies, if anything, the prevalence of pancreas divisum appears to be higher in the no pancreatitis versus pancreatitis groups. This bar graph is similarly constructed, showing the mean prevalence and 95% confidence intervals of pancreas divisum. The top 4 bars show the prevalence of no pancreatitis in each of the 4 groups. For ERCP and MSRP, the bottom 4 panels, the prevalence of pancreas divisum in acute pancreatitis and chronic pancreatitis overlaps with the prevalence of pancreas divisum in the no pancreatitis groups, indicating that there's a similar prevalence of pancreas divisum in acute, chronic pancreatitis, and no pancreatitis. The conclusion from this first set of slides is that pancreas divisum prevalence varies with investigation type. In autopsy and MRCP, the prevalence is about 8% without idiopathic pancreatitis. In ERCP, the prevalence is about 4% in those without idiopathic pancreatitis and 8% with idiopathic pancreatitis. Secondly, the prevalence of pancreas divisum is similar in no pancreatitis, acute pancreatitis, and chronic pancreatitis. Now, one interpretation of this data is that pancreas divisum prevalence is increased in idiopathic pancreatitis. This is the ERCP data. An alternate and more realistic interpretation is that endoscopists underrecognize pancreas divisum in the general population, and that there is a weak or non-existent association between pancreas divisum and idiopathic pancreatitis. The second criterion I examine is that a dilated dorsal duct system should be present if there is a functionally significant obstruction. Now, the point from this slide is that most patients lack a dilated dorsal duct, even when pancreatitis associates with pancreas divisum. A potential but flawed explanation is that the juice flow rate decreases and intraductal pressure increases, but not enough to cause duct dilation. Now, another problem is that tests are not specific for detecting functional obstruction of the dorsal duct. A single uncontrolled surgical study suggests that reduction in duct and sphincter pressures after sphincteroplasty predicted a good outcome. In contrast, secretin ultrasound and MRCP evoke persistent duct dilation, is nonspecific, and occurs in 50% of controls, and there's no difference between pancreas divisum and no pancreas divisum. In idiopathic pancreatitis and pancreas divisum, data is scant but conflicting whether sphincter manometry readings differ at the minor compared to the major papilla. The third criterion we examine is that pathologic changes should develop only in the dorsal duct. The prevalence of ventral duct pancreatitis and pancreas divisum, based on the pooled data from those studies we reviewed, is 11.8% overall. 4.2% have isolated ventral duct disease, and many develop dorsal duct disease over time. The conclusions here are that the presence of disease in both ventral and dorsal pancreas indicates that factors other than pancreas divisum alone are responsible for idiopathic pancreatitis. A weak argument is that the pancreatitis originates in the dorsal duct and spreads to the ventral pancreas, but this doesn't explain why some have pancreatitis only in the ventral duct. The fourth criterion we look at is that the frequency or severity of recurrent attacks of pancreatitis should diminish with drainage procedures of the duct of Santorini. I examine NH consensus comments, a systematic review, the evidence-based review by Mark et al., and reviewed the placebo response. In 2002, the NH consensus suggested that ERCP treatment with stent or sphincterotomy decreases recurrent pancreatitis and reduces pain. A single trial supports, but further research is warranted. A concern are the complications of ERCP treatment for pancreas divisum. I just point out that post-ERCP pancreatitis is 18%. That's the mean rate with broad range in this group. We can prevent complications by preventing unnecessary ERCP. In this systematic review of endotherapy in pancreas divisum and idiopathic pancreatitis, 22 studies were reviewed, and 3 groups of patients were assigned, shown in the table: acute recurrent pancreatitis, chronic pancreatitis, and chronic abdominal pain. The messages from this data are that the response to endotherapy appears to be numerically higher in the recurrent acute pancreatitis group versus the other two groups. Unfortunately, this data is difficult to interpret because there's only a single placebo response, a single sham-controlled trial, and the studies include heterogeneous patients with heterogeneous treatments and definitions, and it's really unclear who these patients are who have acute recurrent pancreatitis and chronic pancreatitis. The 2002 evidence-based assessment by Mark et al. Noted that no study met criteria for review, including the randomized controlled trial by Lance et al. That I show in the box in the top. For the sake of time, I briefly review this study and do not discuss the studies by Kozarek and Lehman, which are retrospective single-arm studies. Lance et al. Evaluated 19 patients with pancreatic pain and ERCP diagnosis of pancreas divisum and randomized them to 1 year of stent versus no stent. The data is shown in the table. The messages from this slide are that there appears to be a reduction in the number of attacks of pain, hospitalizations, and greater pain relief with 1 year dorsal duct stenting. Now, the limitations are multiple. That includes the diagnosis itself, which used atypical criteria for diagnosing acute pancreatitis. Also, this was an unblinded study and is small and with a short-term follow-up of 1 year. The summary of the study by Mark and his evidence-based review was that evidence is sparse and largely uncontrolled, but observations that hospitalizations and emergency room visits were significantly reduced is consistent for the single randomized controlled trial and the less rigorous single-arm studies. Somewhat surprisingly, he comments that this suggests that ERCP treatment reduces hospitalizations and emergency room visits. Now, there are problems with this summary. It ignores that the study of Lance et al. Had multiple limitations we just reviewed, including a short duration of a follow-up of 1 year. Surgical literature has already clearly reported that recurrence occurs within 1 to 2 years. Now, the retrospective studies of Kozarek and Lehman I referred to but didn't discuss also have some similar problems, including recognition that patients may have long intervals between attacks of pain and that there's a significant placebo effect. We really need proper randomized controlled trials of treatment versus no treatment. Now, there's a high placebo response rate in medical and endoscopic treatment of abdominal pain. I address chronic pancreatitis as an example. Now, this systematic review shows the placebo response in medical treatment for pancreatic pain with a pooled estimate of 20% and a confidence interval of 10 to 36. This is very similar to the 35% placebo response reported in the study by Toscas and colleagues for octreotide in a randomized controlled trial, though this only remains in abstract form. It's also interesting that this placebo response is similar to the endoscopic response in the randomized controlled trial of patients with painful chronic pancreatitis by Kane and colleagues. Now, looking for alternate causes of pancreatitis and pancreas divisum, the study by Burton et al. Examined consecutive patients between 2000 and 2008 for patients who had idiopathic pancreatitis with or without pancreas divisum. The messages from this slide are several-fold. First, the majority of patients with idiopathic pancreatitis had a genetic mutation, PRCS1, SPINK1, or CFTR. This proportion increases in patients who had pancreas divisum. It rises to 91%. In patients with idiopathic pancreatitis, CFTR mutations also appear to be significantly higher in patients with pancreas divisum versus those without pancreas divisum. So the message is that pancreas divisum and cystic fibrosis mutations may commingle in idiopathic pancreatitis, but pancreas divisum is not necessary for idiopathic pancreatitis to develop. A case series by Gelrud and Freeman helped to support the idea that there's another potential alternate explanation for pancreatitis in patients with pancreas divisum. They report a clinical experience of 12 patients. The messages from this are that these patients with PD and recurrent acute pancreatitis were rigorously evaluated and had multiple interventions, and they almost uniformly had poor outcomes, with only one patient having symptom resolution. They went on to perform nasal potential difference testing to assess for aberrant CFTR function. This slide shows nasal potential difference testing for several groups, including on the left the control groups, the obligate heterozygotes in the middle, the group with pancreas divisum and idiopathic pancreatitis next to that, and then cystic fibrosis with pancreatic sufficiency, and cystic fibrosis and pancreatic insufficiency. Now, the group with pancreas divisum and idiopathic pancreatitis here are intermediate in this group, suggesting that they have a aberrant CFTR function as a potential alternate explanation for pancreatitis in this group. So I summarize that arguments are weak or not existent that pancreas divisum causes idiopathic pancreatitis. Going through our 4 criterion, the prevalence of pancreas divisum is similar in idiopathic pancreatitis and no pancreatitis. Secondly, most patients with pancreas divisum lack dorsal duct dilation. Third, the pathologic changes supports the fact that this is not localized to the dorsal duct, supports that a generalized pancreatic disorder is likely present. And finally, data is weak or unproven that the frequency or severity of attacks of pancreatitis diminish with drainage procedures of the duct of Santorini. So what are the recommendations? If pancreas divisum and idiopathic pancreatitis are present, other causes should be considered, particularly CFTR gene mutations. If CFTR mutations are found, consider referral to a genetics counselor, and to perform no endoscopic therapy or surgical therapy of the sphincter. Endoscopic therapy causes pancreatitis. It is associated with other complications. We really need to study this in a rigorous way with a randomized controlled trial to determine if endotherapy or surgery of the accessory sphincter is beneficial. Thank you.
Thank you very much, Dr. DiMagno, for this understanding and clarifying talk. Is there any short question from the audience? ¿Alguna pregunta corta? Dr. Domínguez?
Thank you for your presentation. And I have enjoyed very much the picture by amazing. You should be careful with it. So my question is, in your opinion, is there no single indication in a patient with relapsing pancreatitis, idiopathic pancreatitis, the presence of pancreas divisum? Is there no single indication for sphincter of minor papilla sphincterotomy? Never at all?
There's no evidence it wouldn't be an evidence-based recommendation. I think the only way we're really going to answer this, we did for sphincter Vodi dysfunction, but the only way to really answer this is to offer a randomized controlled trial.
I know that. I mean, and I'm generally speaking, I'm against any kind of therapy on the minor papilla, because many times, when you have a patient with many young patients with relapsing disease, no other cause, I understand that people want to do something trying to help the patient. I fully agree with you. But in the case, and this is something that we do in our clinical practice, and that's why I wanted to know your opinion. So we do always a secreting-enhanced MRCP before evaluating anything else. And if the minor papilla is absolutely normally working, we do nothing. But if we demonstrate that there is a clear obstruction at the minor papilla after injection of secretin intravenously, we tend, in a patient with idiopathic relapsing pancreatitis, we tend to do a minor papilla sphincterotomy. Do you think that's right, or we are doing it wrong? There are very few patients individually considered outside any clinical trial.
No, I think those are interesting observations. That's why I included that secreted ultrasound and MRCP data in there. And so based on the data, maybe we need better data. But these data here don't leave you in a place to really use that as to predict the likelihood that this is a causal association or predict the response. I mean, the ultrasound data, they did, the ultrasound secretin study that they did very briefly describe that 2 of the patients, despite the negative data, that 2 of the patients had a very prolonged drainage time, or a very prolonged time until the duct normalized in size. And they said that in those patients that they did benefit. Now, can we generalize? I don't know. That's 2 patients. It's provocative. But if something more rigorously were to be done and in a placebo-controlled way, I think it would address that question. So I guess we just don't know. But based on the evidence, I'd be very careful about doing that. It seems more experimental than anything right now.
Thank you very much. Bueno, a continuación vamos